Mohammed Zaman is a professor of biomedical engineering for the College of Engineering. He also serves as the Associate Chair for Undergraduate Studies and a professor for the Howard Hughes Medical Institute. His research focuses on systems biology of cancer, cell adhesion, and migration in 3D environments. Also cellular mechanics and application of biomedical engineering in the developing world. In his lab, he and his associates focus on the interface of cell biology, the mechanics of that, systems biology, and medicine. And a goal is to develop computational and experimental tools to improve the quality of life, education, and the practice of medicine in developing worlds. Can we welcome him? Thank you.
All right, thank you so much. So it's a real pleasure to be here, and I'm going to talk about something today that we started a few years ago. Can people in the back hear me okay? All right, great. So it's a story, it's a journey, and I hope that this tells you a little bit about where we are and how do we, in engineering, look at problems of people who we'll never meet in far-off lands, in places whose name I find it very hard to pronounce. So for all of us, one of the most prized possessions is our life, right? And within that, I would argue that the best gift is the gift of health. And over the years, we have developed tools and technologies and medicines that allow us to stay healthy, to keep us healthy, to bring health back. And for most of us, these tools and technologies look something like this: pills, capsules, vaccines, syrups, injections. However, often, way too often, these very tools that are designed to keep us healthy, to ward off disease, are the source of misery and death and destruction. I grew up in Pakistan. Lahore is a place not very far from where I grew up. It's where my father's family lives, it's where my grandparents are buried. It's the center of learning, the center of culture, and the center of the best food on earth. In 2012, in over a week, 200 people died by a mysterious illness. Nobody knew what was going on. It turned out that these people, most of whom were very poor and dependent on the government healthcare program, were getting tainted medicines. 200 people in a matter of a week. Many more probably died, but the sense of fatalism that prevails in Pakistan and many other parts of the world stops us from finding out what the real problems are. This was the worst public health disaster in a city that is very dear to me. It would be one thing if this happened once in a decade or so. Very tragic, but one thing. Unfortunately, it happens all too often. Way too often. Even in this country, in 2007, there was a disaster called heparin for a drug that caused the loss of lives, about 70 people. In many parts of the world, the numbers are upwards of thousands. In Nigeria, the number in early 2000s were 23,000. Every year, 750,000 people die. 750,000 people. That's about the size of the entire city of Boston. Every year, gone. Accounts for about $75 billion annually. The problem comes in all shapes and forms. On the top, we see a cough syrup factory in Pakistan. On the right, it's a picture that I took myself. The medicine was on its way to the market in March 2014. Take a look at the expiration date, October 2013. Your eyes are probably better than mine to find out which one is real on the left and which one is not. And if you're a soccer fan like my son, you can get a medicine of your favorite team colors in West Africa. The problem is that we have tools, but they are somehow inadequate, somehow not doing the job. In the top, we see things which have been used for a long time, where we identify what the package is and if the package is real or not. On bottom left, there are tools that cost anywhere from $30,000 to $50,000 a piece in countries where people have $1 a day. On the right-hand side is a tool that you would use in Boston, but not in Botswana. because it's about $150,000. Requires grid power, running water, trained professionals, none of which are available on-site where the problem is most acute. In the middle, we have a technology that is promoted by the World Health Organization, which they consider portable. It's about 200 pounds. So I guess anything that is not bolted to the ground is probably portable. So with the help of students, just like you, smart, talented, brilliant students, we set out to solve the problem. We took small, simple lasers, a bunch of LEDs, small tubing, scan disk that you would have in your cameras, and microfluidic chips that are the size of a postage stamp. I told my students, you want something the size of a postage stamp, and they said, what's a postage stamp? With the help of that, we were able to create technologies that we have been able to take to Accra in Ghana, in West Africa. We were able to train people where they had never been trained before, or their training was costing them thousands of dollars, weeks of time. We were able to train them in 30 minutes. And we were able to do 122 tests in a country in 2 days that did 80 tests the previous whole year. We were able to create a technology that got us very close to the gold standard, under 5% for 100 the price of the technology. Our technology costs about $1,000. HPLC costs about $100,000. Our goal now is to take it to all points in the supply chain, from the manufacturers to the distributors, to the warehouse, to the secondary distributors, to hospitals and consumers. We work in countries which are inherently at the forefront of the most challenging of environments, most challenging of diseases. I've personally seen situations where mothers who are expecting or have recently given birth would bleed and die because their medicines don't work. The times of joy and celebration are times of intense misery and tragedy, and that needs to change. With the help of students just like you and our partners all over the place, from Africa to Asia, from here in Boston to in Botswana, we've been able to address these solutions and are on this journey moving forward. I want to end with a story that we saw in Ghana. So this is Alfred, and Alfred is a technician at the lab where we were doing our tests. Alfred has two kids. One is 4 and one is 8. And both of those kids have had malaria. And for him to go back home, bring back the drugs that his kids got, and to be able to test them himself and find out what his kids are getting was the single biggest achievement of anything that we've done in the last 5 years. So I know I'm way short of time, but I'll end with a simple message. It's still all about life. The most important possession, the best gift possible in life, still is our health. But our hope is that we will achieve that gift and live life to the fullest if we have not just medicines, but safer medicines. Thank you very much. So I have to apologize. I thought it was 10 minutes, but not 15. So clearly I don't read my email as well as I should.
Two questions.
Yeah. I've got some people here that I know. Some of them are in my class, bright and early tomorrow morning. So, all right, questions? Yes, and please tell me your name as well.
My name is Kevin. So what are a lot of these unsafe medicines? Are they like purposely unsafe, or are they just, poor conditions on the ground?
It's all of the above. So you have cases where we have seen malicious intent, and they are sort of purposefully designed to trick and really lead to bad consequences. There are cases when they're supposed to be in the fridge and they're out in the open, so they degrade. There are also cases when we've seen that the manufacturing practices are not what they were supposed to be. And there are cases where good and bad medicines get mixed up because of many of the challenges that are there. One of the things that I told my students when I was teaching on this, I started off my field trials in Ghana, in Accra, and in Accra there's the facility where all medicines come in and then they go back into the system, right? So it's called the Central Medical Store. That's where we did most of the testing. And on January 17th, earlier this year, I got a phone call from a friend, and he said, have you seen the news? And I wasn't sure what he was talking about. It turned out that the entire facility got burned down. About $200 million worth of drugs gone, right? So, I mean, you're dealing with many challenges at once. And this is not just malicious intent, it's governance, it's poor manufacturing, it's regulatory issues, and that's what makes the problem really complicated. But it's not to say that it is not malicious intent. We have seen cases which are clearly bad practices. So one of the things we saw from Myanmar were drugs which were supposedly anti-malarials, and they were actually just Tylenol. So you would give it to the kid, the fever would come down, and the mom would think he's getting better. In fact, it wasn't doing anything. And the kid eventually would die because it's not an anti-malarial. It just brings down fever for a few hours. Yes?
My name is Madina. I just want to understand why they would maliciously intentionally use that medicine.
Can you repeat the question, I think, for someone?
Should I repeat?
Yeah.
I don't understand why they would give bad medicine to people intentionally.
So I think it's the same argument as you would have with crime, right? So I mean, there are economic incentives for people to create these kinds of things because they can make lots and lots of bad medicines for low price and don't have to sort of go through the regulation. And certainly their ethical compass is not where it needs to be. And it's in many ways it's criminal. It's playing with people's lives. I mean, there's no other way to put it, except for financial interests at the cost of the lives of the most vulnerable people. Yes, can I take one more question? Just one quickly, all right.
Yes, how many different kinds of medicine can be tested with one device?
That's a great question. So, and that's actually one of our biggest challenges. There are tens of thousands of medicines. So what we start with is a list of essential medicines that the World Health Organization recommends to save lives. And within that, we have looked at the ones that are known to be most commonly substandard and counterfeit. So we are going after the biggest targets, that is malaria, TB, drugs for postpartum hemorrhage, and antibiotics. But certainly there are other drugs as well, but these are the ones which are called essential life-saving medicine. So if somebody doesn't get a cancer medicine for a day, most likely it's going to have a bad effect, but it's not going to lead to death immediately. On the other hand, in some cases for antibiotics or antimalarials, the consequences of not taking it at a given time are very, very dire. So we go after these essential medicines, and right now we are working on antimalarials, anti-TB, antibiotics, and what are called uterotonics for postpartum hemorrhage. All right, I got an indication that that's my time. Thank you very much.